Welcome everyone to this month's discussion from the Neurogastroenterology and Motility Journal. My name is Dr. Purna Kashyap and I'm a gastroenterologist at Mayo Clinic, Rochester, Minnesota. We're very fortunate to be joined here today by Dr. Drossman and Ms Jordyn Feingold to discuss their recent review published in the current issue of Neurogastroenterology and Motility. Dr. Drossman does not need an introduction. He was one of the first gastroenterologists to ever develop the field of brain-gut interactions and neurogastroenterology in terms of research, patient care, and education. Dr. Drossman is a professor emeritus of medicine and psychiatry and gastroenterology at the University of North Carolina School of Medicine, where he in fact founded and co-directed the Center for Functional Gastrointestinal and Motility Disorders. In addition to his leadership position in almost all major national societies in our field, he's also served on 3 committees of the Institute of Medicine on Gulf War and Health responsible for gastrointestinal disorders. Another major contribution by Dr. Drossman to our field is the Rome Foundation, which has helped advance the diagnosis and management of the disease of gut-brain interactions. He was the founder and president of the Rome Foundation, and now he serves as a president emeritus and chief of operations. Ms. Jordyn Feingold is a 4th-year medical student at the Icahn School of Medicine at Mount Sinai. She's working towards her combined MD Masters of Science in Clinical Research, studying the gut-brain axis and the psychosocial experiences of patients with chronic digestive disorders. She has a master's in applied positive psychology from the University of Pennsylvania, where she graduated with honors for her capstone work on physician well-being as a conduit to enhancing patient health and well-being. She's the co-author and founder of a longitudinal well-being curriculum at Mount Sinai for all medical students called PEERS, which is Practice Enhancement, Engagement, Resilience, and Support. Welcome, Dr. Drossman and Ms. Feingold. Congratulations on your recent publication, Deconstructing Stigma as a Barrier to Treating Disease of Gut-Brain Interaction, Lessons from Clinicians. You're one of the founding fathers of the field of gut-brain interaction. So Dr. Drossman, before we go into the specifics of the review, I was wondering if you can provide us with more of a 10,000-foot view of how the field has evolved since you first started here.
Yeah, that goes back a long way, Purna. I do think I was there seeing the evolution. If you go back in history, really at the beginning of the 19th, 20th century, these disorders were really just symptoms that people treated. And as the field of gastroenterology evolved, getting into the beginning of the 20th century, a lot of focus went toward pathologic conditions like ulcers, IBD, cancer, pancreatic disease, and the like. And when patients had symptoms where there was no structural basis, they were called functional, but they were very amorphous. They didn't have any real organizational structure. And then around maybe the late 40s and early 50s, some investigators, Tom Almy and others working in New York at Cornell, decided to do motility testing, which opened the field of motility. And the presumption there, and I say it's a presumption, was that by understanding these pressure waves that exist, they could define these conditions. And so that led to a lot of research using tubes through the GI tract, motility studies, looking at pressure waves, and certainly there was value in looking at diarrhea or constipation based on migrating motor complexes and various other motility abnormalities. But what began to become evident is that while motility like diarrhea, constipation, vomiting could be based on correlations with pressure changes in motility, certain types of symptoms like pain or nausea didn't correlate. And what that did is it led to a recognition, I will say by the Rome Foundation, to develop symptom-based criteria, which meant that diagnoses were not based on specific motility abnormalities, but based on symptom clusters. And it was based on the work of a good half dozen people, of which I was fortunate to be one of them, who were doing epidemiologic studies. And we were finding clusters of symptoms that defined the condition. It's kind of like anorexia nervosa. There's no physiologic or biomarker for it, but it breeds true. You know it when you see it based on the collection of symptoms or findings. And so that led to a new paradigm, which was not structural abnormalities or motility disorders, but what we call functional GI disorders. And that period from about the 1990s with the Rome criteria until maybe about 5-10 years ago, functional GI disorders was understanding these symptoms which were not defined by structural or physiologic abnormalities per se. The last element came with Rome 4 in 2016, which was to change the term from functional GI to disorders of gut-brain interaction. A couple of reasons for that, which we can get into later, but one reason was it often meant that we didn't know what was going on, or it meant that it was psychiatric. In fact, our group surveyed the AGA in the 1980s, and the number one definition of functional GI was absence of a disease, and the second was psychiatric. So by calling it disorders of gut-brain interaction, we started to meld or harmonize with the emerging science of gut-brain interactions, which helped to understand them. And in that way, it legitimized it for patients. And that's where we are now.
It was really fascinating to hear that evolution. And it really drives into the next point that I want to bring up, because you described the evolution of how we actually went from, trying to define people based on their symptoms, and we've made such significant progress. But an important concept you discuss in the review is stigma, which seems to have carried on from then to now. And I think it's something we still face with our patients in our day-to-day lives. Can you elaborate on this further, especially in the context of the functional gastrointestinal disorders or the disorders of gut-brain interaction? And you think this applies only to patients? And this is meant to be provocative because we are all physicians treating some of these patients. Or so do you think the same stigma also applies to physicians treating some of these patients?
Oh, absolutely. And I'd like to, again, give you this historical perspective. And I think Jordyn might be able to say what it's like in the medical student environment, how they receive this information too. So to understand this, you need to go back to the 17th century, or even before that, there's always been a harmonization or a shift between what's called holism, the integration of illness into the person, and dualism, which is the separation. And the ancient Greeks, for example, always talked about integrating mind and body together, beginning with Hippocrates and other ancient Greeks. However, into the 17th century, there was no ability to understand this because the body couldn't be dissected and we couldn't understand disease and illness. And that was based on the church in Western Europe saying that the spirit resided in the body, and that led to the lack of dissection or autopsies to learn medical science. And then what happened is in the 17th century, René Descartes in 1637 published a treatise about the separation of mind and body, which is the genesis of the concept of dualism. And what he said was that the body was machine-like, only serving functions, but the mind was separate from the machine. And the church adopted that to mean that the spirit was with the mind. And as a result of that, the body could be dissected, and there were surgical suites developing, and we learned morphologically about structural abnormalities like ulcers and tumors and the like. And that opened the door to further science of disease, when I say disease, objective observation of abnormality, which was pathology, histopathology, and then the next few hundred years, X-ray imaging, magnetic resonance imaging, SPECT scanning, and all of these were morphologically based. So what it led to by Descartes creating this dualism was that disease was understood based on morphologic abnormalities. But then what was happening with people who didn't have it? And if you talk about at the time, people who had symptoms or behaviors that were not explained, they were thought to be possessed, and then later insane. And then they were put in asylums. And the dominance of the church was such that the asylums couldn't be studied scientifically. And in fact, Benjamin Rush was one of the first to talk about a medical school curriculum, which didn't, in mental health, which didn't occur until 1905. So, I'm sorry, yeah, 1905. So mental health came late in the understanding of medicine. So what that led to were centuries of recognizing disease as legitimate and bona fide scientific causes, whereas behaviors or symptoms without structural findings were then considered structural. But in the social unconscious mindset, it meant it was either not real, possessed, or psychiatric. And that has permeated the way doctors and patients think about it. In many ways, patients are struggling with that because they go to the doctor with symptoms and the doctor says there's nothing wrong. And the doctor, not having adequate training in understanding the biopsychosocial model, for example, don't know how to communicate, and they actually experience their symptoms as second class or psychiatric and out of their realm. And that can lead to discomfort. And the discomfort that the doctor may have in not knowing what to do could have negative attributions where the patient could be stigmatized, as you say, as a way to offload their sense of unclaimed responsibility for knowing what to do.
Jordyn, do you want to build on that?
Absolutely. So I think everything that Doug says still rings true in medical education today. We very much are still operating in a medical model where the basis of what we learn in medical school is really what we can see and diagnose. And there is very little about the integration of the mind and the body. Of course, we learn excellent communication skills when we interview patients and we learn about psychiatry. I think what's missing is the link between how the mind and the body reinforce one another and the deep integration of these things as we see in disorders of gut-brain interaction. So I think that we have to go there in medical education and build some of these discussions and concepts into our curriculum, because as Doug is saying, if we're not teaching emerging doctors and trainees how that these diseases are legitimate, they can feel incompetent when they're faced with these patients who are suffering with symptoms without any quote unquote underlying cause that can be diagnosed with imaging or endoscopy. And then I think what that fuels is a lot of burnout on behalf of the physicians too, because their training and what they're experiencing are not aligned. They don't have necessarily the knowledge to treat these patients and to offload some of that cognitive dissonance of, I don't know how to treat this. It ends up laying in the with the patient that they need to go see someone else, and that it's quote unquote all in their heads.
That's great. I think in some ways it was really nice to hear Dr. Drossman, lay out the history, because it almost seems like this is a problem of our own creating, and we've perpetuated it, and now we have to find a way to solve this. I just wanted to ask just a follow-up question, because I think there's a challenge because physicians are not trained, and as a result, they may land up stigmatizing patients. But what about physicians who treat these patients? And maybe Dr. Drossman, you've seen the field evolve. how do you feel they would view you early on when you were treating these patients with functional gastrointestinal disorders? And over the years, do you think the respect has grown for physicians who actually treat these and consider this as a one concept and legitimize it? Or, there is still a large swath of the medical community which looks down on people who treat these patients?
Absolutely. Yeah. Well, of course, I remember in the 80s and 90s when there were political issues going on between the motolologists and the functionologists, where the motility people were saying there is no science here. You need to have scientific investigation to explain it. Well, there are two factors there. One was that the science hadn't evolved to do brain-gut interactions. So they would say, well, these patients have pain. We just don't have a more sensitive transducer to pick up the pain, but it didn't work. So there was that downplaying of the people who were viewed as very soft scientists. We were relying on clinical research, using psychologic measures, using epidemiologic research, which was not considered as bona fide as basic or later translational science. But what we did with that was to use factor analysis to identify clusters of symptoms that define these categories that bred true. And as time went on, the acceptance started to grow because when we started to categorize these conditions, we developed a database of patients who fulfilled these criteria, the Rome criteria, and then we were able to do research on them. You see, prior to '88, there was no criteria. And in fact, Ken Klein, who worked with me, did a paper in Gastro pointing out that there is no standard method for making a diagnosis, and all the studies in treatment are flawed because you'd have patients with diarrhea and patients with constipation and patients with no bowel movements all in the same study. So once we started to use criteria and they began to be accepted around the world, we were able to have a cohort of patients to study that brought us onto this new wave of science of visceral hypersensitivity, mucosal immune dysfunction, the microbiome, brain-gut interactions. None of these could have been done if we used motility to try to define this population. So we've seen this evolution of acceptance. Still, middle-aged to older doctors still tend to stigmatize this condition as not real, and that may play out on the patients. Whereas the younger doctors who are being trained with the use of Rome guidelines, the Rome criteria, and are learning communication skills, how to interact with patients, are picking it up. So I think if we did a survey, we would see an age cohort effect.
Absolutely. And even in my short career, I've seen an increasing number of fellows going into neurogastroenterology. Even when I was going into it, I was more of the exception than the rule. But I think now there are more and more fellows going into this, which is really encouraging. And I'm guessing if the journal would have started now, we would have started with a very different name for the journal than what we have right now.
Yeah, Pern, if I can add something to that, terminology is very important, and we've learned that. And so by changing it from functional GI disorders, which has that history, to disorders of gut-brain interaction, we find it that patients accept it better because they're getting a physiologic explanation. And it rolls off the tongue of doctors better, although initially they have to say DGBI, but they're able to have a basis to explain it to patients and to their cohorts. And in the same way, it was with Rome 3 that the term neurogastroenterology came into play, of a subspecialty that's dealing with neuromodulators. We don't say antidepressants and antipsychotics because those terms were based on treating patients with psychiatric disease in the 50s and 60s and 70s. And when we borrow that term, it has a stigma. But by calling them neuromodulators, We can talk about central neuromodulators, the antidepressants and antipsychotics and anti-anxiety, and peripheral neuromodulators, which all gastroenterologists are familiar with, the 5-HT3 antagonists, the delta liganes, the chloride channel agents. Those are all acting on the enteric nervous system, so they're peripheral neuromodulators. And so by creating that harmony, we can move forward in unity.
That's great. And, it really builds into the next part of the discussion, because I'm going to start by asking, how does stigma impact patients' acceptance of a diagnosis? And does it really drive them into this vicious cycle of healthcare seeking that we often see in our patients to find a validated diagnosis that they can share with people? And so maybe I'll start with Dr. Drossman, and I'll have Jordyn follow up after that.
I'll say it briefly, but I think I want Jordyn to talk about that vicious cycle diagram we have, if you can show that. But basically what happens is the vicious cycle begins with the patient with the mindset that something structurally must be found. So they go to the doctor, and the doctor might embrace that initially. They have abdominal pain and they think about working them up. And the problem with the DGBIs is that the endoscopy and the CT scans and the blood work just isn't going to show anything, which can lead to a sense of frustration. And the doctor can respond by pulling away, telling them you have to learn to relax at stress, or doing more tests, which is self-defeating, or referring out. The patient in return gets more frustrated and they go to another doctor, or they respond by a self-indulgent response of, there must be something wrong with me. This must be, maybe I am crazy. So both of those are ineffective. And if they go to other doctors, the cycle continues because the doctor does more tests, more referrals, and same responses. And you have to learn to break that cycle.
And at the end of the day with this cycle, we have patients in distress who are experiencing very real symptoms. And in this vicious cycle, as patients are overly attuned to the sensations that are in their guts without any sort of explanation from a physician, maybe it's just stress, maybe it's something serious, but they don't know. What ends up happening is that these symptoms can actually become more noticeable and more severe and lead to greater frustration, helplessness, and as this diagram says, feelings of lack of control and even self-blame. So these individuals who are suffering from very real symptoms that may not be seen with imaging tests, that are not seen with imaging tests, end up internalizing this notion, maybe there's something wrong with me, because the doctors have not explained to them that there is this phenomenon of gut dysregulation of the gut-brain interaction. And even as a medical student in the emergency department, I saw some patients who were coming in after seeing 7 doctors for symptoms, and no one found anything. And some of these patients are feeling incredibly desperate and incredibly helpless. And Doug, I actually want to know what you think about this. I'm an emerging psychiatrist, and one of the diagnoses we learn about is somatic symptom disorder, which is perseveration over a somatic symptom. It could be abdominal pain, and these patients often get extensive workups with nothing seen. And I wonder, in many of these patients who are diagnosed with a psychiatric disorder, somatic symptom disorder, in your experience, have you seen that really what they're suffering from is a disorder of gut-brain interaction?
Oh, absolutely. What you're dealing with, somatic symptom disorder, is a derivative of what's often been called afferent spectrum disorder, where patients can have anxiety, depression, and multiple symptoms. And if we think about the brain-gut axis, and we think about signaling coming from the level of the gut, going to the second-order neurons and up to the brain, and when you have GI symptoms, it's not uncommon to see that these patients might also have fibromyalgia and chronic fatigue syndrome and TMJ and low back pain and endometriosis. And you begin to wonder, when there's not a lot of morphologic loading, why are all these symptoms occurring? Do they have 10 different conditions? The answer is no. We're talking in the brain-gut axis at a failure of the brain to downregulate these incoming signals. Normal regulatory symptoms from the body go to the brain, but then the brain has a sense of central sensitivity, not visceral, where these signals are not handled well. And so it's like there's no filter anymore, and you report all these symptoms. So patients understand better that there's a physiologic disturbance in the brain's regulation of these signals rather than it's psychiatric. And similarly, in terms of the distress, the psychiatric symptoms, hypervigilance, catastrophizing, selective attention, are all derivatives of the chronic symptoms. So it's easier for patients to understand that their GI symptoms have led to distress, anxiety, depression, hypervigilance, selective attention, and so on, then their mind is somehow causing their GI effects to occur. The reality is that it's bidirectional. This is a bidirectional system where there's no cause and effect. It's a vicious cycle. But what gets seeded with chronic illness are these comorbidities that patients can respond to better by understanding it as derivatives of their pain.
And I think that makes sense why we see in a lot of patients who have quote unquote organic disorders like Crohn's and colitis, IBD, that they too have what really appears to be dysregulation of the gut-brain interaction. They too have quote functional symptoms even when disease is well under control.
Look, the association between symptoms and pathology, or even symptoms and physiology, are very low correlations, like 0.3. I mean, Jay Pasricha, you know this, Purna, pointed out that there's no correlation between symptoms and physiologic emptying with gastroparesis. And the same thing here, you can have Crohn's disease with no symptoms, and you scope them and they've got really severe disease. On the other hand, you take the patients who go on biologics for Crohn's or ulcerative colitis, and they go into morphologic remission. They have maybe minimal mucosal inflammation or none at all, and they still have pain because they've developed a post-inflammatory IBS. So the correlation of expecting to see something is not always there. It's what we expect. But when you do IBD studies, your outcomes are not the symptoms as much as more improvement in the biology to know if it's responding.
You know, as I listen to both of you, I realize this is not a simple concept, and it's not a simple concept for physicians, which makes it even harder to convey it in a meaningful way to patients. And I think we can get into that a little bit later on. But I did want to focus briefly on the paper, which actually triggered this review, because you helped summarize the findings of a paper which was published in the current issue of Neurogastroenterology and Motility by Dr. Yan and colleagues from Shanghai, China, who found that stigma adversely affected patients with functional dyspepsia, resulting in reduced adherence to neuromodulators and less symptom improvement. So that's, can you comment more on these findings and their implications, and more generally in how stigma impacts treatment response and adherence?
Well, Jordyn did the heavy lifting, so why don't you talk about it?
Sure. So as you beautifully summarized, Purna, we saw in this, Jan and his colleagues identified in this study that stigma, and they identified internalized stigma. So really believing these negative attributions about oneself, and perceived stigma. So the perception that others have stigma towards you, and that could be family members, physicians. So stigma undermined treatment adherence to neuromodulators, which are also known as antidepressants. And I'm not actually sure the language in translation in China where this was done, whether antidepressants are called antidepressants. I think that would be something that is important for us to know, as language is so important. But the higher stigma was associated with less adherence to these medications, and that was associated with less symptom improvement. And this population of note were patients with refractory functional dyspepsia who also met criteria for generalized anxiety disorder or major depressive disorder. So psychiatric diagnoses that are highly correlated with disorders of gut-brain interaction. They're also highly correlated with IBD, by the way. So these correlations between mental health and physical health are not just seen in the disorders of gut-brain interaction, but also in the quote unquote organic disorders. So they did an intervention and they prescribed these antidepressants or neuromodulators to these patients. And what they showed was that after 8 weeks of treatment, 68% of the participants actually had higher internalized stigma scores at the end of their treatment, and 75% showed elevated perceived stigma scores after treatment. There was also a great deal of shame, it seems like, among participants for taking the antidepressant medications. That was measured by a 4-item questionnaire, though there was a slight decrease in stigma against the antidepressants over time. And for patients for whom the stigma increased, there was worse adherence and symptom response compared to those who had less stigma over time. And overall, what's so interesting is that in the whole cohort, functional dyspepsia symptoms, depression symptoms, and anxiety symptoms were significantly decreased at 8 weeks. And so we're seeing a lot of effects. And of course, there was no control group here. This was all patients who were prescribed these medications. But overall, the findings indicate that the more stigma there is, the less likely patients are to respond, to adhere to the medications, and therefore respond and have symptom reduction. I think what's promising about this is that once we can understand these effects, that stigma is present and it undermines adherence, we can help modify it. So especially for physicians who we're invested in their training and education, is that we can at the very least not contribute to perceived stigma, and at best actually help to intervene on it. Because stigma is, I believe, and I think Doug would believe, is something that's modifiable. So there are several ways that we can do this, and this is a big focus of Doug's work in his communication workshops and in his recent book, Gut Feelings, that I think should be required reading for all medical trainees. But I think that there's a lot that we can do as clinicians really to anticipate stigma around these disorders and intervene on it with our patients so that we can increase adherence and increase the likelihood that our patients will get better with these medications.
You know, if a doctor doesn't believe in an antidepressant or sees it as a psychiatric drug, and they don't believe that the dyspepsia or IBS or whatever it is not a legitimate disease, how in the world could a patient be convinced of the value of the diagnosis and the treatment? So it really is an issue of communication. There is a study by Lyndale a couple of years ago where they looked at patients who were diagnosed with functional GI or DGBIs and those with organic diseases, ulcers and IBD. And they looked at the terms that the doctors used in their letters and in their record. And basically, when the doctor was talking about ulcerative colitis or Crohn's, they said, you have ulcerative colitis, you have Crohn's disease, you have pancreatitis. When they talked about dyspepsia or IBS, they said, well, the studies are negative. You may have dyspepsia. We may want to do a few more tests to rule something out, but then we'll start you on treatment. And in another study similar to that, the patients walked away and when asked, stated the doctors never gave me a diagnosis because they did it in such a limited way, a qualified way. And in addition to that, in this Lyndale study, the patients who had organic disease had fewer colonoscopies and endoscopies than the functional GI patients for obvious reasons, because they weren't certain of the diagnosis. So that's the message, that patients need to have a valid diagnosis. They need to be told, you have this and here's why. And you can do that with diagrams, discussion, dialogue. You don't just give a brochure, because that's not going to register the same way as an interaction. But that's a way to hopefully avoid that misunderstanding and the stigma.
Thanks, Dr. Drossman. I think you were referring to the study which came out recently in neurogastroenterology and motility. The positive diagnostic strategy is safe and saves endoscopy in patients with irritable bowel syndrome, which is a 5-year follow-up of randomized control trial. If not, I just wanted to point out, because this is good to see these kind of studies coming out, which I think reinforce that message. I just had a quick follow-up. You think cultural factors have something to do in terms of how stigmatization occurs, and also how we would reverse it? Because there might be parts of the world where the stigma is more prominent and inbuilt, not only among physicians stigmatizing patients, but also family members or others around you, or a population around you, creating that stigma.
Well, yeah. So Asians tend to have less acceptance of psychiatric problems, or at least don't communicate psychiatric problems as well as Western cultures. Even within the U.S., you know, if you're coming from Southern California or New York City, you're going to be more willing to talk about psychological issues than the Deep South. So there are even cultural differences in the reporting these psychological issues, and so that does need to be taken into consideration. Rome Foundation did a workshop on cross-cultural communication, because they were trying to teach what's called cultural competence, to understand enough about the culture to know what to do. Very simple things. This patient-centered care is a very Western phenomenon, where you ask the patient to participate and to make decisions with you, and you help guide them. Well, that has to be modified if the person is from India, where the culture, or other Asian countries, where the doctor is seen as the expert, and they don't want to question the doctor. So if the doctor says, what would you want to take? They'll say, well, you tell me, you're the doctor. We see that in African cultures as well. So you need to reframe the way you're doing it by engaging the patient in a way that lets them know that you are the expert, but you're needing them to help you make those decisions. And then the person will be more readily participate.
And having trained in India, I can definitely second that, because that's exactly how we used to feel. Yeah. But I'm going to circle back to what we were discussing in terms of the obvious question is how can we break stigma to improve outcomes of patients with functional GI diseases?
Well, I'll start, and then the first thing I believe is the legitimization of the disease, of the illness, and you have to understand that for these conditions, there's a wealth of supportive evidence that the Rome criteria identify conditions that have scientific bases. And so if you fulfill the criteria and you do the screening diagnoses, you don't need to keep doing other studies, because the data show that a sound diagnosis the first time with adequate initial evaluation gives you like 99% confidence that that's the diagnosis, and you just stay vigilant. So say the diagnosis with assurance, and once you know the diagnosis, you have opportunities for treatment. The second thing I believe is the teaching of communication skills. As Jordyn said, we have I have a group called Drossman Care, which teaches workshops, and we collaborate with the Rome Foundation for train the trainer sessions, We may start getting into patients, but right now we're doing it with physicians and trainees, how to do patient-centered care, how to interview, handling of difficult issues, like the patient wants a CT scan when it's not needed. How do you address when the patient wants narcotics when it's not indicated? That kind of training, I think, will make a difference. Another thing is we need incentivization for teachers to do that. We don't want to get a gastroenterologist to get paid 10 times more for doing a colonoscopy in an hour than in spending an hour helping a patient with chronic pain. We need to change that system through curricular reform and through federal reform of reimbursements. But that's my next goal, is to change the healthcare system. I'll see if Jordyn has any other thoughts.
Yeah, and I think just from very early on in our education, as I said, teaching our future doctors and reinforcing throughout training for residents and early career clinicians through CME that these diseases exist, and that interventions, really low tech interventions such as communication and validation and fostering a high quality therapeutic relationship, are actually indicated as treatments for these disorders. We don't need to start kicking our patients down the line to physician after physician because we haven't found something. What we need to do is stick with these patients, and it would be great if our system incentivized us to do this by more frequent visits with our patients, where we can have these high quality relationships. I also think I'm very interested in this topic of clinician well-being and clinician burnout. And I think so many of these communication skills will help build competency and autonomy for clinicians to feel more in control of their interactions with patients. In the clinical environment, where there are so many things that are outside of the scope and doctors feel out of control, we really want to help them gain control and competency in these areas, especially with their patients, where it's the doctor and the patient in a room. Instead of feeling helpless and this complaint is outside of their scope of practice, really to equip them with the skills to treat the patient in the room, and over time see improvements in their patients and regain that sense of autonomy and control.
There's strong and emerging data to show that good communication skills leads not only to patient satisfaction, but doctor satisfaction, thereby reducing burnout, adherence to treatment, and improved outcomes, including biologic measures like reduction of A1C, lowering of blood pressure, and the like. So it's the communication training, learning that is therapeutic. We just did a study from patients at Hopkins where we looked at which items in the patient-doctor relationship lead to patient satisfaction in care. And some of the items were somewhat surprising. Liking the doctor, if that was the number one item. Feeling that the doctor understands what they're saying is another item. Feeling a sense of trust, and so on. So there are several items that indicate that it's not what you do, but how you do it. When you look at HCAHPS, which is looking at satisfaction, patient satisfaction, it's really doing it for billing purposes, for reimbursement. And so they're asking, do you get your medicine on time? Is the room clean? But when you ask patients what determines satisfaction, of course you want the doctor to be competent, but you also want them to be humane and interested in their psychosocial world and communicating about the impact of the illness. Those skills lead to satisfaction and better clinical outcomes. And I guess I want to put a plug in for Gut Feelings. Gut Feelings is a book that just came out 2 or 3 weeks ago. It was done, there it is on the screen. It was done by myself and Johanna Ruddy, who's the executive director of the Rome Foundation, who's a patient of mine who then became a patient advocate, and her career has exploded because She's so articulate now in working with patients, and we do workshops together to teach communication skills. So the book is a catalog of all the DGBIs, all of them listed, and it's for patients or doctors. And there's a very good part talking about brain-gut interactions, the biopsychosocial model, how do you explain it? And then there's sections on communication for patients. How do you deal with a doctor who seems too worried or isn't listening? What do you say? What do you do? And for the doctors, what do you do for the non-adherent patient, and so on? So I think it's a great book because I think it puts it all together in a way that I think harmonizes. Maybe, how did it affect you, Jordyn?
I felt so validated reading this book. I think the way I had never sat down and read through the Rome criteria. So this was just an awesome way to put together all of the DGBIs, to really see them one after another, and then have really practical strategies. It goes into mind-body dualism and the origins of stigma. And when I read it, I really just felt that this needed to be required reading for medical students. I think in our medical education, we have one lecture on IBS. Maybe it's mentioned in 2 lectures in GI pathophys, and the rest of the DGBI are not mentioned. So when I talk to my medical school colleagues, none of them have ever heard of these things. And it was just by great fortune that I came to know Doug and his work through my mentor, Dr. Kiefer, who works in our IBD center as a GI psychologist, excuse me. And I just feel so fortunate to have this inventory of tools and it really an arsenal of skills that I think all medical students should have and all doctors should have, but it's not really taught in our traditional medical education.
You know,
Arna, I guess you'll have a link to the book if anybody wants to get it.
yeah, I'll on the video, which we'll post on YouTube, I'll post a link to the book, and that way people can look at it, and I think it'll be really good reading for our readers who want to learn more about this. But also brings into question, as we try to wrap up this conversation, which is obviously, we could go on for hours, but an important thing which I feel both of you brought out was that this is a really important aspect of patient care, which is lacking from the traditional training models. And Doug, you alluded to this earlier, that this is one of the goals, is to be able to train physicians and growing minds in terms of being able to do this. To me, this sounds like these skills are not just limited to DGBIs. These are almost an essential part of medicine, because they would apply to any disease state, because communication and how you communicate is important in any disease state. And so, where should this start in training? And is it narrow enough that it should be a part of a curriculum where everybody learns it, or is it, required to be a subspecialty of its own, which gains more recognition as time goes by?
I think a subspecialty of its own kind of is existing to some degree with people teaching communication or the neurogastroenterologists. But that tends to offload responsibility away from the doctor who has to learn it. I remember when I was at UNC and we were going on consult, the medical team would say, we come up with this case and talk about biopsychosocial principles, and they would follow it, and they'd say, yeah, but that's Dr. Drossman, he's the expert. It's nothing I should do or I could learn. And so we really have to make it really training for everybody, because as you said, it involves all medical conditions. Within medicine, there are the functional conditions like fibromyalgia, chronic fatigue, all of these, and then the structural conditions, as we talked about, adherence to treatment. All of those things involve patient perceptions that need to be addressed through good communication to reverse that. So I think it has to go back to the medical schools. I think there has to be CME courses, which we're doing. Rome Foundation are doing CME courses on communication programs. I think it has to be, and I think most of all, it has to be reimbursed and it has to be researched. We need to show more evidence. Most of the work is coming out of primary care, that within GI, that this makes improvement in not only treatment adherence and outcome, but costs and reduction in procedures, which does occur, but it has to be studied.
Okay, thank you. That was sort of all the questions that I had, but any parting thoughts before we close?
I just feel so fortunate, and I hope our listeners do too, to hear the evolution of this field directly from Dr. Drossman. And I'm just so excited to be starting my career, and the floodgates have been opened, and the uphill battle that I imagine it was for you, Doug, to literally create this field, you've enabled my colleagues and myself to enter freely and to contribute to this work. And as a psychiatrist, I hope that I will work very closely with GI doctors and potentially be embedded in a GI practice or in a functional, a center devoted to functional and disorders of gut-brain interaction. So I'm just very excited about the collaboration and the partnership and my ability to enter this field with you as our pioneer.
Yeah, it was great working with you. As you've guessed, I'm a teacher. I love to teach, and the collaboration with Johanna and the book, it's a real great experience. I want to mention something that is relevant here. Are you familiar with hedonics and eudaimonics, ancient Greek terms?
I'm not.
So what we look for in our life could be hedonics. Hedonics means pleasure. It could be, food, traveling, sex, but meaningfulness is a different domain. And the ancient Greeks talked about eudaimonics as finding meaningfulness in what you do. So if I were to ask you, either of you, what do you find pleasurable, you could quickly come out with it. But if I said, what do you find meaningful in your life, you might think a bit, and you'll come up with one or two things that are very, very that are wonderful goals. And I think that for me, the meaningfulness has been doing this work because I see the meaningfulness come in others who follow.
And
Definitely.
By the way, that is the basis essentially of the entire field of positive psychology, which I think has massive applications in GI. And Lori Kiefer, my mentor who connected us, Doug, is doing tons of positive psychology work in our IBD center and helping doctors and patients find their eudaimonia and their sense of meaning as a therapy for their condition. So I think this is relevant for doctors, for patients, really for all human beings, to focus on the good life and not just chasing pleasure, but really finding sustainable well-being and meaningfulness.
Yeah, I know. And like I said, I think we are still waiting to find meaningfulness, but that it was really nice to hear from you as you've seen the field evolve. You were there at the beginning, and you've actually moved it to a place where it has transformed care for patients and for the better. And very, very few people who can actually claim that over a career. And I think just the fact that there was a non-existent field which you bought in, and it was a field which was one of those harder ones to deal with, which people didn't want to believe in, and so converting the non-believers into believers is not a small feat. So I think it really been really nice hearing you describe this path as you've come across, and it's really nice to hear that you're not done yet, that you still have things planned for the next 20 years. And that's what really inspires the younger generation at this point.
Thank you very much.
Yeah, and with that, I'd like to thank you, Dr. Drossman and Ms Feingold, for this excellent discussion and, of course, these pointers. I would also like to thank our listeners for tuning in. I hope you enjoyed this conversation. And if you need more, you can always look at links which are associated with both the video and the podcast. I look forward to welcoming you again on another exciting discussion next month. Thank you.
Bye.